Good evening, everybody. A warm welcome to all our panelists and the audiences to this day 4 of the certificate course of hypertension management in a case-based approach. So I'm Dr. Nishita, and I'm part of the medical team of Sardia. And I would like to welcome our three speakers for today, Dr. Jai Gopal sir, Dr. Ambud sir, Dr. Murthy sir, who are here to discuss some very interesting and relevant topics. I'm sure with a panel like this, we are all going to have an intellectual feast. So before we begin with the session, I would just like to give a short introduction of what Sardia or Servier is all about. Next slide. So for those who are not aware, we are headquartered in Paris, and we are in a non-profit foundation. This is something which separates us from the other pharma companies. This specifically means that we do not have shareholders. We are not listed on the stock market. This has its advantage and disadvantage. The advantage being that we are independent to take our own decisions. And hence we invest a very large amount of our turnover in profit, nearly of very large amount of our turnover back in research, back in R&D, that is nearly about 25%, which is way high as compared to the other pharma companies, which invest about 4 to 5%. And also a disadvantage of this kind of a system is that we do not have an access to the investors' money, and hence we need to generate our own profits. Next slide. So Sardia or Servier supports the brands produced in India. So we have all our medicines produced in India, even though the API is produced in a single factory in France, and it is sourced to all the countries from that single factory. So your patient receiving a Servier medicine in India would be of the same quality as that of a patient receiving the Servier medicine maybe in Latin America, Middle East, or Europe. So we do not use any Chinese API for any of our medicines. So I would like to now tell you all about the agenda for the day. So we start with Dr. Ambuj Roy's presentation. Sir is going to tell us about management of hypertension in patients with heart failure. The talk would be for 15 minutes, followed by a 10 minutes panel discussion and a 5 minutes Q&A. And then we have Dr. Murthy's talk, which would be on improving patient adherence in hypertension and diabetes, following the same pattern. I would like to introduce, next slide, I would now like to introduce our very esteemed Dr. Jai Gopal sir, somebody who actually does not require any introduction. He is a big name in heart failure. So sir currently is Director, HOD and Senior Interventional Cardiologist at Lakshmi Hospital in Kerala. Sir is the Vice President of the Indian College of Cardiology. He is an Executive Committee member of National Cardiological Society of India. He has been a Principal Investigator and National Coordinator of Heart Failure Registry of the Indian College of Cardiology. Sir is on the editorial board of the Indian Heart Journal and has been a co-investigator in multiple studies and has numerous publications to his credit. Sir, thank you for joining us. It is indeed a pleasure to have you with us. And with this, I would like to hand over to you and request you to take the proceedings of the session ahead. Also, we would request you to kindly introduce our two esteemed speakers for today. Over to you, Jai Gopal, sir.
Thank you, Dr. Nishita, and thank you, Servier, for this wonderful initiative. I think something to be really congratulated about. I think we have today two eminent speakers. Of course, Dr. Ambuj Roy needs no introduction. He's a very popular speaker, and I think he's a big name, particularly in the field of heart failure. My association with him has been for the last so many years now. I'm quite glad to introduce Dr. Ambuj Roy to this webinar. He is currently the Professor of Cardiology, the Facility Coordinator in charge skill, e-learning and telemedicine, which is very relevant in the COVID era. He has been the National PI and Steering Committee member of the famous Inter-CHF trial, the Global CHF trial, and co-investigated many multicentric trials. You just heard about the CREATE, InterHeart, the STITCH trial, Freedom and Umpire, Yoga, and the Ischemic trial. He was a former convener of the Heart Failure Council, and I heard him speak in so many occasions. I've always been really fascinated by his lectures, and I'm sure you'll have a wonderful academic feast. Our second speaker for the day, so Dr. Ambuj Roy is going to speak on heart failure and hypertension, which you all know is a very relevant topic today. Hypertension definitely is on the rise. We have our statistics from the country which says that close to 1/3 of our population is suffering from hypertension. And not only that, I think the major challenge that we face these days is heart failure. So I think the combination of heart failure and hypertension is something really challenging. And I think you have a lot of insights to this particular area from Dr. Ambuj Roy. My pleasure to introduce Dr. Professor Srinivasa Murthy, who's a senior consultant physician and diabetologist at Bangalore Life Care Hospital and Research Center. He has vast experience in both undergraduate and postgraduate teaching. He has faced world's first ever Canadian audit outside Canada successfully, principal investigator for many trials, more than 65 trials, and part of the organizing committee for the National Conference of the Epicon 2018, numerous publications to his credit. He's an executive committee member of the RSDI and many organizations, life member of many organizations. So he's also going to talk on a very relevant subject, particularly in a country like India, where the adherence to treatment, all of us would agree that one of the major challenges that we face is to see that our patients take medicines regularly, whether it's heart failure, whether it's hypertension, whether it's diabetes, acute coronary syndrome. So we're going to hear from him as to what we can offer to our patient in terms of better patient adherence. So without much ado, I would now invite Professor Ambuj Roy to give his presentation. Thank you.
Thank you, sir, for a very generous introduction. It's always a pleasure to be with you, whether physically or virtually. We look up to you for the kind of great research that you combine right in the private sector also. So thank you for the introduction. And if I can get my slides on, yeah, I'll just put it there. And so to speak on management of hypertension in heart failure. It's a bit of a paradox in a way, because I'll tell you why, because hypertension does lead to heart failure, but most of the times things change once heart failure sets in. So, I've been asked to have an interactive session and put some questions out. So I'll start with a question on hypertension and heart failure. This is very relevant to all physicians to understand the importance of management of heart failure. So the first question, as you can see on the screen, is antihypertensive therapy, we know, reduces various complications of hypertension, or what are called now HMOD, hypertension-mediated organ damage. But I would like to ask you whether you would like to answer this question, what is the relative risk reduction of which of these complications is the highest? Is it ischemic heart disease? Is it stroke? Is it renal failure or heart failure? That is, which is reduced maximally when you treat hypertension.
Yeah, so we give you 20 seconds to vote. Please press on the option which on your screen.
Mr. We haven't got any options.
So y'all will not get it, sir.
It's not for you. It's not for the expert.
No, y'all will not be able to see it. It is only for the people who are on that side.
Fair enough. Yeah. So we are past the exams. We are passed already.
So I'll just show the result. So 63% have voted for heart failure, and 18% have voted for stroke.
Yeah, so obviously, great. I mean, I think everybody knows what we are talking about, so I don't know whether we need to talk further, but I'll just continue. You're right. Actually, the heart failure is the complication that is maximally reduced when you properly treat hypertension. And across different trials, if you see, the incidence of hypertension is reduced remarkably when hypertension is treated. It's about 64% in the elderly trial, HIVET, Hope, which had much lower blood pressures, reduced it by 13%, 48% in the classical SHEP trial, and the VA trial, which was one of the first trials which treated very high blood pressure, 100% reduction in when you treat it. And there was 100% reduction in the incidence of heart failure. We know that it's second most is stroke, so that is also right. And third is heart disease, which is reduced to about 25%. So this is very important that when you treat hypertension, you reduce heart failure significantly. For the second question, and it relates to the little bit of the topic, and that's why I said it's a bit of a paradox, the topic, is we know hypertension is a common cause of hypertension, heart failure with reduced ejection fraction. And if you see among the causes, ischemic heart disease is the most common cause of heart failure with reduced ejection fractions. Second, most of the time is hypertensive heart disease. But my question to you, have high blood pressure in patients once they develop heart failure? So
yeah, so 20
increases.
seconds.
Yeah.
Also, there is some issue, sir, with your screen. It's your video is getting duplicated, sir. If you can stop sharing and share it again, or else the host, please, can you help us out with it? How should he share it? Kaustubh, can you please tell us?
Please share the PPT, sir, not the Zoom screen.
Okay. Is it okay now?
No, sir. You have to share the PPT. There's an option.
Meanwhile, the audiences can poll. We'll just sort out the issue till then. Yeah, Kaustubh, please tell, sir.
Use the green share screen button and open the PPT.
Is it okay now?
No, sir.
It's okay. Isn't it okay? Isn't it fine if we do it like this?
It's okay, ma'am.
Okay.
Let
yeah.
me then try to close the other.
It's okay. We'll just see the results. So 56% have replied the last C option. 21 and 21 have replied A and B.
Yeah, so again, that's the right choice. So paradoxically, if you see the blood pressure drops when you, once the heart failure sets in. And this is obviously due to the low cardiac output that sets in. And it's been shown in some of the people who respond extremely well to CRT and their LV function, who are super responders, and their LV function becomes normal. There is an increase in blood pressure once the LV functions reach normal levels. However, some of them may, and this was a classical paper by Oakley long back, which where he showed that people who improve their heart function, their hypertension comes back. But if they persist with heart failure, then the blood pressure, even if they've had hypertensive heart disease, usually is low. But in some cases, you may have persistent hypertension in heart failure patients. And then how do you manage? What is your choice of drugs? So if you have, obviously, if you have heart failure, you are expected to be on a RAS inhibitor, you're expected to be on a beta blocker and a loop diuretic. But if blood pressure continues to be high, it's a good idea to switch from ACE, ARB to ARNIs, which are more potent hypotensives. Use a vasodilating beta blocker like carvedilol, nebivolol, rather than other beta blockers. And if you're diabetic, add SGLT2 inhibitors. So these will, because I mentioned these drugs because they already are known to further improve outcomes in heart failure. Even if then it's not controlled, add spironolactone. And if still not, then you might look at adding other drugs like thiazide, like diuretics. But what is the correlation? Actually, once when the heart failure sets in, what is the correlation between blood pressure and outcomes of patients in heart failure? So does higher versus lower blood pressure is associated with poor outcomes in patients, or higher blood pressure is associated with a good outcome in patients with heart failure?
Okay, so 20 seconds to vote. Last 5 seconds. Okay, so 71% has voted for A and 28% has voted for B.
So 71% you said for A.
A, yes.
Okay, so finally the majority got it wrong. So
Oh.
actually, paradoxically, higher systolic blood pressures have a protective effect on survival once heart failure sets in. And it has been shown that for each 10 mm lower systolic blood pressure, there is an 18% risk of death, 11% higher risk of death or hospitalization, and a 9% increased risk in the combined risk of death or hospitalization. So what I mean to tell you is that, most of these patients are no more hypertensive. They have low blood pressures when heart failure sets in, and they're actually having a higher blood pressure is better, probably because you can then give them the maximum benefits of the cardioprotective drugs of heart failure, like ACE inhibitors you can use in higher dose of beta blocker, higher dose of ARNI, higher dose of aldactone. So that's why a higher blood pressure is actually protective once heart failure sets in. So that's a kind of a paradox in hypertension, blood pressure and heart failure. But coming to what the topic as it was today, what about patients who have hypertension and heart failure, that they have hypertension in patients with heart failure? And let me share 2 cases with you. This is a 35-year-old lady who presents with progressive shortness of breath with class 3 symptoms for last 3 months. There is a past history of transient ischemic attack. 1 year back, her pulse, she's tachycardic at 102. She has a raised blood pressure, 156 and 104 millimeters in the right upper arm, and 148, 102 in the left upper arm. She has mild pallor. She has a CVS with an systolic murmur at the apex, borderline LVH on ECG, and echo showing severe LV dysfunction with moderate MR. So a middle-aged lady with hypertension, with past history of TIA, and LV dysfunction. So what is the likely diagnosis you would think of? Does she have premature ischemic heart disease? Does she have non-specific aortoarthritis? Will you think of fibromuscular dysplasia? Will you think of hypertensive heart failure?
20 seconds to vote.
So while you vote, it's in all patients who have heart failure and hypertension, it's very important to look. As I said, most of the people, once the heart failure sets in, will have relatively low blood pressure. But in those who persist to have heart failure, as in this lady, it's very important to look for.
Sir. Sir, there is a duplication issue. Please share your slides again, or give me a remote access of your device, sir.
Please accept the request, sir.
Sorry?
Please accept the request of remote support.
I haven't got any.
Please accept the grant.
Okay, I've done that. I was saying in these patients, it's very important that you look for secondary causes for hypertension, and many a times you may find treatable causes for heart failure, as in this lady. So
make it slideshow mode. Make it slideshow mode, sir.
It's sorted now?
Yes, sir. Fine.
Okay. So I will just show the result. 72% have voted for hypertensive heart failure.
Okay.
And 10% have voted for A and B, and 7% for C.
So again, it's important, look at the context. It's a middle-aged or literally young lady. She has had a TIA. She has LV systolic dysfunction. So in these cases, we must think of non-specific aortoarthritis, because often the young women, they have hypertension. You should have looked for bruit in these patients. It's important to look for carotid, subclavian, or renal bruit. And often that's a hint to hypertension and a stroke, because they often have the renal artery involvements. So these are very, very potent hints to look for secondary causes. And these are treatable causes. If you treat the disease and you look for absent pulses, you should have actually measured the lower limb BP in this also. And as you see, there was LV dysfunction, which is usually disproportionate, because many of them have associated myocarditis, and usually they'll have raised inflammatory markers like ESR and CRP. As this patient underwent an angiogram, and you can see there was clear descending, there was aortic stenosis with renal artery stenosis, and post-dilatation, there was remarkable improvement in blood pressure and remarkable improvement in LV function. So these are treatable causes of heart failure. You should always keep this in mind when you're treating a young lady with heart failure and hypertension. So coming to the second case, which is again a 65-year-old diabetic with hypertension, and he has the relatively well controlled most of the time, as his home monitoring showing. He is post-CABG, post-CABG. He presents with acute onset severe breathlessness, and there is a history of similar episode 3 months ago, treated in an ICU for 4-5 days. He's tachycardic, as you can see on the screen. He has again an accelerated hypertension with a BP of 180 by 112. His chest is full of rales. His CVS has S4. He has emergency investigation shows mild anemia and raised creatinine. So again, a case of heart failure with hypertension, which I said does not happen usually in my initial slides. So you should look for other causes. So what do you think is the likely diagnosis? This is my last question. If I bored you with too many questions, so this is the last one.
So 20 seconds. I think, sir, your questions are very difficult.
No, I think they got most of them right.
Ten more seconds.
So I can give you a hint. Pickering syndrome is referred to bilateral renal artery stenosis. So whether it's uncontrolled hypertension, is it pheochromocytoma, is it Pickering, or is it hypothyroidism?
Okay, so I'll share the results. They have said uncontrolled hypertension, 71%.
Yeah. So as I mentioned, that these patients had usually good, decent control otherwise, and he had a flash pulmonary edema and with very high blood pressure. And in patient who has atherosclerotic cardiovascular disease, that is, he has post-CABG, so he's a diabetic, he has all the risk factors for CVD and already has CAD. In such patients, when they have flash pulmonary edema, always think of atherosclerotic bilateral renal artery stenosis. This was described in a classic paper in 1988 by Thomas Pickering, and that's why it's called the Pickering Syndrome. In all such patients, again, I'll emphasize, who has cardiovascular disease or multiple cardiovascular disease risk factors and have this kind of presentation of flash pulmonary edema recurrent, as this patient I mentioned, this was the second episode, think of bilateral renal artery stenosis. So the predictors for flash pulmonary, Pickering syndrome are presence of functional bilateral renal artery stenosis. They could have stenosis in the both arteries, or there could be solitary kidney with renal artery stenosis. Remember, this is very different from single renal artery stenosis, as I will let you know. And the presence of CAD is a predictor of this. Blood pressure levels and renal function usually do not predict presence of Pickering syndrome. So when to suspect? Elderly hypertension, as I said, associated risk factors of CVD or presence of CVD. Mildly deranged renal functions is usually present, and there as the history of flash pulmonary edema, usually nocturnal, because they lose their nocturnal dip. There is actually a reverse dip in these patients, and their blood pressures are higher during the night times, and that's why they develop these episodes more often than during night. The pathogenesis is increased left LVEDP due to LVH, which is invariably present due to loss of or reversal of dip, and very importantly, impaired natriuresis. These patients have bilateral renal artery stenosis, so perfusion to both kidneys are low. So that's why natriuresis is impaired. If you have single renal artery stenosis, the other artery has higher blood pressure and compensates with natriuresis. So usually this does not happen. And we have multiple trials of single renal artery stenosis which have not shown much benefit by revascularization. But this disease is very different from single renal artery stenosis. Remember that. Management, of course, acute is oxygenation, diuresis, and decreased pulmonary and measures to control blood pressure to reduce pulmonary capillary wedge pressure. However, sometimes the over-aggressive treatment will, reduce perfusion to the kidneys and cause hyperkalemia. So be aware of that. Don't over-diurese them. You need to have strike a sweet spot there. But renal revascularization, once stable, is extremely useful. And in this series, there was a reduction of blood pressure of 52 by 27 millimeters, and there was marked improvement in the creatinine levels also. And there was complete elimination of flash pulmonary edema. There are other series by Franz Messerelli who have also shown that almost 87% patients did not have flash pulmonary edema. And the odd cases where flash pulmonary edema may occur, think of a revascularized kidney, because it should be almost curative if you treat bilateral renal artery stenosis with revascularization. So this is an important, again, to keep in mind when you have patients of heart failure and hypertension. Other things you should think of are things which should come to your mind when you see a patient of hypertension and heart failure are coarctation of aorta, again, completely treatable. That's why every patient of heart failure should have an assessment with a 3-limb blood pressure, so that at least in the first go, so that you do not miss, again, a treatable cause. This usually occurs in either in the first decade of life or in the 5th decade of life when coarctation presents with heart failure. Other causes of renal artery stenosis should be in mind, like fibromuscular dysplasia, again occurs like aortoarteritis in young women. Neurofibromatosis in children can cause renal artery stenosis. And so in children with hypertension, heart failure, think of that. CKD can often present with high blood pressure and renal failure, both HFpEF and HFrEF, and endocrine conditions like pheochromocytoma or thyrotoxic heart failure, where you have isolated systolic heart failure with high output renal or high output cardiac failure is something which should have in mind. Or even aortic dissection patient can present. Of course, they'll have more chest pain, but they can present with hypertension and associated AR, which can give you acute LVF. So these things you must have in mind when you see both heart failure and hypertension in the same patient. So that's all I would like to say. To be an astute clinician, this is what William Osler had said. It's very operate. Keep using all your 5 senses, and you need to clearly be alert in seeing, hearing, feeling, and smelling it out, the disease in the patient. Thank you so much.
Thank you, Dr. Ambuj Rai, for a very enlightening talk. I think Dr. Ambuj really emphasized the need for a good patient assessment to really pick up some treatable causes for hypertension. We all know that, someone comes at a younger age with high blood pressure, one has to really rule out a secondary hypertension. Fair enough that, when you start looking at hypertensive population, and more so in the context of patients with heart failure, majority of them may not have an attributable cause, and they fall into the category of essential hypertension. But I think it's a good clinical rule to go all the way and then just to pick up some treatable causes like the first scenario. In fact, really wonderful case scenarios. The first one, particularly, I think somebody, young patient below the age of 40 years comes to you. I think it should be a routine habit to look for the pulses. I think I really wanted to stress this point. I keep telling my fellows and my students also about the need for real good assessment. Again, to look for bruise, not only in the peripheral over the femorals, but also sometimes over the in the abdomen, over the renals, will really give you an answer, and that will make your suspicion. I mean, you can always go ahead and confirm the diagnosis. The second scenario where, the patient's coming with flash pulmonary. In fact, I had a very real fascination for these patients because we have seen these kind of cases time and again, going to the physician, getting admitted with a flash pulmonary edema, getting discharged within a couple of days on hypertension therapy, but then no regular follow-up, and then again they land up. And I think one of the clinical scenario where, the way you see high blood pressure, but not features of fluid overload. In fact, you find that they have just a flash pulmonary edema, and then the next day morning, somebody does an echo, they say the normal systolic function. So I think, so this is something which is often overlooked, and it's indeed nice that you brought about this case, because, until and unless you look for this renal arteries, you will never pick up, and it's a absolutely treatable cause. A couple of questions to you, Dr. Ambuj, is, we always have a subset of patients when you look at heart failure, and those patients, as you rightly said, those guys with a high blood pressure, they do well. And in fact, I am happy to receive a patient who has a high blood pressure and heart failure. You know that these patients do well in the short term as well as long term. And when they present to you, some patients have really bad LVs, to the extent that people have even made a diagnosis of dilated cardiomyopathy, not looking at the thickness of the left ventricle, but at the size. They down the line, the pressures are well controlled, and they come back to you 3 months later and find normal LV function. So I think this is a very important sort of a scenario, which I think, again, and what do you think about their long-term outcome? So these are sort of patients who have a near normal LV, and also the second thing is, today the ARNI has become the mainstay of treatment. These people are on full dose of ARNI, and once their LV function recovers and becomes absolutely normal, do you think you can de-escalate them to the next level, maybe an ACE or an ARV back?
Yeah, that's a very relevant question, actually. So I would say, obviously the costs are a bit of an issue. If it was not, I would continue them at least for a year, since till when they have recovered on an ARNI and a beta blocker for sure. And there is a very good study just come up last year in Lancet, which showed that if you don't do that, there is a chance of relapse. So they have looked at RAS inhibitor and beta blocker, which must be continued. But I would say ARNIs, especially if that has helped out, should be continued for at least 6 months to 1 year. And then we can think of de-escalating to RAS inhibitor. I would often think of that. I don't know what you had in mind, Dr. Jayapal, if you have something.
Yeah, see, the thing is that, because being a very costly drug, down the line, as you rightly said, we have data to suggest that 1 year, the LV function really remarkably improves. We have the evaluate HF, prove HF trials and all that. So we know for sure that this works. But I think that perhaps the most important thing is the proper control of hypertension, which has helped this particular patient. So if you are able to control the blood pressure well at the end of 1 year, the same concept of going back to ACE or ARB, it should work well. I think if the hypertension is controlled, and that has given the sort of improvement in LV function, and if you are able to control hypertension in whichever way, with the combination drugs or whatever, I think that's, just looking at the cost factor, because we don't have any long-term data with ARNI. So I think I'm just a hypothetical situation, but we tend to see these kind of patients who have recovered very well from a heart failure, LV improves. And another important thing, I think, is
I was saying, especially if the heart failure is not there now, definitely what you're saying is a good idea.
Yeah, once LV improves, I'm talking about a subset of people who have had good improvement in the left ventricular function. Second thing, I think clinical rule, I need to stress again the importance of looking for potassium. See, even on day one, when you see somebody with hypertension, I have had patients being referred at myocardial infarction, potassium consistently 2.7, 2.8. Again, another treatable cause, primary aldosteronism. This is often overlooked, and it's not as so rare as one would think about it. In fact, sometimes you can even have a normal potassium, but when the potassium is definitely low, in the absence of a diuretic, I think this is a treatable cause where your spironolactone really comes in, and then we have had patients who have had primary aldosterone worked up and then found to have tumors, which has been resected. And so I think key thing is to again look for potassium, which has to be re-emphasized. Dr. Srinivasmurthy, would you like to add a comment?
Yes, sir. I think I have a question to Dr. Ambuj. The role of SGLT2 inhibitors in these heart failure settings.
Yeah. So I'll just say about the Conn syndrome, which you were talking about, sir, before I come to SGLT. So I would even say, the low dose diuretic that we use, not the loop, if that also gives you hypokalemia, which should not, with the small doses of thiazide diuretics that we use for hypertension, and if that gives you hypokalemia, that can also be a clue to presence of the primary hyperaldosteronism. So it's a little difficult to investigate in our settings because it's, the ARR ratio is not very easy to measure and it requires a bit of a nice, good lab to do that. But you should always think of that because, again, a treatable cause for both hypertension and heart failure. Yes, about the SGLT2, yes, obviously after the DAPA-HF, it is clearly coming up as a management of heart failure, not only for the diabetics, but also for the non-diabetics. So I would say right now, definitely in all diabetics, we should be heading towards a SGLT2 inhibitor. In non-diabetics, despite the other known drugs like the RAS inhibitor, the beta blocker, and the MRAs, if you still are persisting with heart failure symptoms, and there is a scope to add, you can think of adding SGLT2. It is definitely a excellent addition to the armamentarium of heart failure management. It's only that the armamentarium is increasing so much with the latest Victoria trial showing another new class of drug, the variciguat. So that armamentarium is becoming too much, and it's going to be polypharmacy. But yes, this is a definite addition which will help in heart failure patients.
So another basic question about echo finding. Grade 1 LV diastolic dysfunction is seen in most of the echo reports what we come as physicians. So how do you go about such patients?
So I would increasingly we do. If a good echo should give you EE prime, and there are new diagnostic criteria to diagnose HFpEF as compared to, and the European Society has just come up early this year with the new guidelines for diagnosing HFpEF, and it lays much more stress on not just type 1 diastolic dysfunction, which is extremely common beyond a certain age in all patients. So I wouldn't, but I would ask all echo facilities to give an EE prime ratio, and if it's more than 15, that's a very simple measure to do. That is much more indicative, and if there's a large LA volume, if the TR gradient is more than 2.8, if there is LVH, those are much more better indicators of presence of HFpEF than just in diastolic dysfunction. I think Dr. Jayagopal, you might like to add on that.
Yeah, I mean, I fully agree with him. In fact, this is every other echo report above the age of 60 years, you will find this kind of stage 1 diastolic dysfunction. In fact, I don't really think that, do not try to interpret too much from that. But then E bar, E prime, I think that's perhaps the way to go about. And again, in the context of somebody having a left ventricular hypertrophy and things like that. In fact, we also sometimes look into the LA volume index and things like that, because little too difficult for a physician to interpret. And I think in a routine practice becomes difficult. But again, look for E bar, E prime. In fact, whenever you want to know about the diastolic dysfunction, ask your cardiologist that this is what we are looking for. I think that's perhaps the stage 2 and stage 3 are perhaps more important as far as the cardiologist is concerned. One final question to you, Dr. Ambuj, is in the scenario of hypertension, atrial fibrillation, heart failure. I think that is something which is very common because we are getting an aging population, CKD patients. I think the commonest reason for a secondary hypertension is a parenchymal renal disease. And these people today with the modern dialysis and things like that, they survive for a much longer time. But the challenge again is they come to you with recurrent heart failure even on dialysis. And again, one of the precipitating causes is atrial fibrillation. So even without CKD, hypertension, atrial fibrillation, heart failure, how do you approach this? The diastolic parameters may not help except for the E bar, E prime. Yeah. So your comment on that?
So I would say atrial fibrillation most of the time is an indicator itself of a worse LV, and itself an indication that your LA pressures are high, and that is what is giving you. In other words, it's an adverse marker, and sometimes itself an indicator that patient may be going into HFpEF or may already be in HFpEF. So in terms of management, of course, the first line is getting, if it's a first episode, we always try to cardiovert, either medically or by cardioversion by electrical shock. if he comes within the first 24 hours of the episode. Otherwise, give a good anticoagulation 6 weeks and try pharmacotherapy. If it doesn't respond, then we do the cardioversion. Definitely in the first episode, if the LA is not too large, you should try to cardiovert as far as possible. But of course, if it's chronic AF, where the LA is quite large, there's MR, where the chance of maintaining sinus rhythm is more difficult. A rate control strategy is what we would generally follow. But generally, AF, as you're saying, is a marker of worse outcomes in patients with hypertension and heart failure.
And do you prefer an ACE, ARB to an ACE there in heart failure with hypertension? Too theoretical, I know, but
no, I know. I would clearly prefer an ACE over ARB any day, because if you see most of the data, whether it be initially, is with ACE inhibitors. Very little data on ARB except losartan data. And one of the commonly used drugs is telmisartan, which really has no data in heart failure. So.
Okay. Yeah. Thank you, Dr. Ambuj. I think we have had a wonderful discussion, and as you always, yes, given us a fantastic talk and an oversight into the possible treatable cause of hypertension, and I'm sure there's been a lot of learning for this. I think for want of time, we have to go to the second speaker, and now Dr. Krishnamurthy.
Can we just take one or two questions, because a lot of them have come up, and
okay, so sorry. Yeah, I thought we were running out. Okay.
So we'll just take one or two maybe. So what should be the goal for systolic and diastolic blood pressure in established heart failure? Dr. Rajoy from Mumbai is asking.
As I said, most of the time you will not need a goal for heart failure, because most of the people will have relatively low blood pressure once the heart failure sets in. But yes, if it's, as I said, if the blood pressure persists to be high, the goals are clearly less than 130/80 in these patients.
Role of carvedilol in heart failure with hypertension with preserved or reduced ejection fraction?
Yeah, that's a good question. For reduced heart failure, obviously carvedilol is one of the 3 beta blockers that's recommended, along with bisoprolol and metoprolol succinate. So one of these 3 can be used. Carvedilol is a little more hypotensive than the other two antihypertensives, because it has a vasodilatory effect. It's an excellent drug, very good outcomes in class 2 to class 4 heart failure patients. So it is to be used, and the dose should be optimized. Not only to be used, the dose should be optimized to the maximum tolerated levels. Was there a second part of the question?
It was the same thing. It was the role in reduced or preserved ejection fraction.
Yeah, in preserved heart failure, there is less data of beta blocker. Like any other drug, there's very little data on anything in preserved heart failure. But yes, if you are hypertensive, it will be a good drug to use anyway to control blood pressure. But I would prefer ACE/ARB over beta blockers, and even consider an MRA in this situation, and HFpEF with hypertension. But Jacopo, you would like to add to that?
I think perfectly right. So the only thing is heart failure, the goals are the same, 130/80. The ESC recommendation is the same, 130/80, whether it's reduced or preserved. But then the drug, as you said, in a patient with preserved ejection fraction, you don't want of course, the heart rate has to be maintained for the LV filling to be adequate. So I think you may not have to go to that kind of a dosage, because you're worried about bringing the heart rate very low also. But I rightly pointed out, when you use carvedilol, you have to get it at the right dosage for the desired benefit. So which becomes pretty expensive. And only caveat, it's a non-specific beta blocker. So some people have a chronic obstructive airway disease, then it becomes a little tricky to use this drug. Otherwise, it's a very good option.
Perfect. So we have a lot of questions, but because of paucity of time, we won't be able to take it. So over to you, sir.
Yeah, I think without wasting much time, I think we'll go to Dr. Srinivasamurthy's talk. He's going to talk on the subject of adherence to medications and what we could offer. Over to you, Dr. Srinivasamurthy.
So good evening all. I hope you can see the screen, sir.
Yes, sir. We can see it.
Yeah. So I think the most difficult task in our routine practice is making our patients to adhere to our visits and to our advices, and that happens both in hypertension and diabetes. And that's what we are trying to look at today, about the evidences for this adherence and what are the factors which influences and how to tackle that. So let us begin with a case. Mr. CK, 55-year-old businessman, complains of lethargy, morning headache, fatigue, frequent urination. He's a diabetic for a year, hypertension for 2 months. He was worried about his habit of skipping medications, and he was not agreeable with multiple tablet regimens due to frequent traveling and tight work schedules. This is a typical patient I'm sure most of us get in our routine practice. And he suspected to be having a poor control on his diabetes and hypertension for weeks together, but he was not finding time to come to the hospital. Of course, this was before a COVID era. Now COVID era, the commonest cause is because of the COVID. And looking at his social background, erratic food habits, frequent traveling, work stress, irregular food habits, and irregular medication intake. Father had a diabetic CKD, mother resistant hypertension and stroke. This is his family history. So examination, the BMI is about 23, BP 160/100, A1C 9.2, and remaining physical examination is unremarkable. And currently is on metformin BD, glycoside BD, enalapril OD, hydrochlorothiazide OD, and simvastatin, plus vitamins and calcium supplements. So end of the day, we have a patient, typical Indian diabetic patient who's got an uncontrolled hypertension and diabetic. So let us begin with a discussion on this case. So we would request the audience to poll or answer these questions. Why did you notice, what did you notice in this case? The treatment non-compliance and irregular at follow-up visits, lot of pills, all of the above, or none of the above?
So 20 seconds to vote.
So I'm sure all of you would be noticing in this case is definitely a non-compliant patient, a typical Indian patient, I would say, who's irregular at follow-ups, and he's definitely got multiple pills. And the answer I expect it to be number 3. I'm sure Dr. Nishita will tell us.
Yeah. 87% have replied. 3.
Okay.
Yeah.
So the 13% of the people, I think they're not awake. So they have switched off their cameras and not listening or not reading to the case. Of course, that's on a lighter note. So the next question, how would you categorize this case as a hypertensive diabetic because of poor adherence, or only uncontrolled hypertensive, or a diabetic only, or he's got a background clinical condition of probably CVD, or none of the above? So what do you suspect or categorize? How do you categorize in your practice before you initiate or plan the management schedule?
20 seconds again to vote.
So we are trying to figure out this root cause and try to categorize this patient and then work up and then treat. That is what we do in our routine practice. And this is what typically we do in our routine OPD practice on a daily basis. So what are the answers, Nishita?
Yeah. So 70% have replied hypertension and type 2 diabetes mellitus due to patient non-adherence, and 30% have replied clinical condition of CVD.
Okay, so as we are all intelligent, so we are blaming the patient that the patient is non-adherent, hence is diabetic and hypertensive, is not under good control. Fair enough. But remember, in this era of evidence-based era and consumer forum era, we need to be careful about this, because we need to document if somebody is not adherent in your routine prescription to safeguard yourself in case of any legal implications in the future. So next question, please start voting. How would you identify the poor adherence? So most difficult task because of the lack of time, because the numbers what we see in our routine practice. So will you interview using a questionnaire? Will you take a pill count and refill data? Will you directly observe, or all of the above? How do you identify the poor adherence? When do you suspect a patient walks in second, third, fourth visit to you? And how do you guys identify that this patient is bad on respect to his diet and exercise, or his pill adherence, or the lifestyle adherences? So what are the methods you incorporate in your routine practice? That's what you would like to know.
So 88% have replied all of the above.
Great. It has to be multi-pronged because each patient is individual by themselves, and we need to identify each patient who's smarter than us, and definitely they get caught over a period of time, may not be on the first or second visit. The next question is, how do you manage the treatment? So as we said, we try to identify the root cause, figure out the solution, and then depending on each patient, we individualize the treatment. So in this patient, how do you want to manage? Non-pharmacological approach, that is diet and exercise, or you want to counsel, about the disease more and about the complications and the importance of adherence and the implications if somebody doesn't adhere to this regimen, and or you want to modify prescription to reduce the pill burden, or all of the above?
Okay, all of the above, 70%.
Yeah, great. I think that should be the approach in our practice, to identify the root cause and try to figure out and correct all the aspects. So let us look at what should be our approach to improve the patient adherence and some evidences for the same. So we know by definition, compliance is the extent to which the patient, while taking treatment, complies with the clinician's advice and follows the regimen. So if you look at the patient adherence in diabetics and hypertension, they slightly differ. In diabetics, the dose omission was the most commonest form of non-adherence. That means they skip a dose. So about 75% of the diabetics do this, whereas in hypertension, the non-adherence to the drug therapy was the main cause. So we need to be having this basic knowledge about when we treat about an anti-hypertensive drug or an anti-diabetic drug. So look at this slide, which talks about the gap between the real world setting and the clinical trial setting. All of us know clinical trial setting is a controlled environment where the patients are regularly followed up through the physical visits, to telephonic visits, and by the entire team of the clinical trial, which in real world setting, we do not have that kind of control on our patients. So this gap is basically, if you see this, is 75% is due to non-adherence. What we see, the gap between the real world data and the clinical trial data is very, very clear that 75% of this efficacy gap is because of poor adherence to the therapy what we give. So look at this slide, which talks about the patient adherence to therapy. 62% take tablets correctly. That means 40% of them do not relate to the food. Before, after, during the food, they do not abide what you have instructed. 20% of regularly forget to take the tablets. 5% omit because of high sugars, 2% omit because of low sugars. So this is what is the practicality, what we see with our patients, which many of them fail to tell us. Most of them hide, especially with insulins and OHAs. They say, no, the pills were increased, so I took one alternate days. I took half of it, 40 mg is more, so I took 20 mg on my own because BP was 120/80. This is what the excuses we give, we come across in our routine practice. And look at this adherence and the OD, BD, and TID. Once you make the drug TID, there is a 50% drop from once a day regimen. Once a day, 80% adherence. When you make it TID, it is about 38%. So more than 50% drop. This shows about the different drug classes of OHAs and the adherence rate. Look at all the 4 classes mentioned here, and none of them cross more than 50%. So this is what is the practicality we should accept, and we should be very cautious when we counsel, when we prescribe medications in our busy practice, to counsel them for this adherence and the implications of non-adherence. And this is an interesting article which said about the risk factors for non-adherence in the anti-hypertensive treatment. And if you look at this, in this study, the non-adherence was 41%. And remember, for every additional pill, the non-adherence worsened by 85%. So that is something to be worried. Every additional pill from 2 to 3, 3 to 4, the non-adherence increased by 85% in this study. And this talks about the various landmark studies like Wikipedia's or Heart study, wherein they required more than 2 drugs to bring down the BP. In a controlled environment like all these landmark trials, they require 2, 3, sometimes 4 drugs to control hypertension. So remember, the controlled environment requires more than 2 drugs, and the real world data, the real world practice, we definitely face more problem, and most of our patients would require more than 2 drugs in real world practice. And this is what the least we want to see with our patients, the complications or the consequences of poor control of hypertension or diabetes. I'm sure all of you are aware about this. And what are the factors leading on to this suboptimal adherence? Basically, it's a multidimensional, and it's about 5 factors. 1, social and economic. 2nd, healthcare system. 3rd, condition related, therapy related, and patient related. The patient related can be the denial. The first time when you say diabetic or hypertensive, they literally are in a denial mode. They go into depressions, anxiety, they never come back to you, and they may look for alternative therapies. Some powders are given where the diabetes vanishes. Some creeper is swallowed and the diabetes disappears. These are all the beliefs patient want to go into those kind of treatments. So these are the patient-related problems. Similarly, condition-related, they may have multiple comorbidities like depression, they may be dependent on alcohol, chronic smokers, and major disabilities. Therapy-related, when you prescribe more complex regimens, and the healthcare system, the communication style, the patient centeredness, or lack of team-based care, the what you call as a whole approach to the patient or the disease is not there in many of the centers of the hospitals. And the socio-economic, like the social support is not there, the lower income, poverty, all these factors, these are basically 5 factors which are in the adherence. And this is what is the factors which we need to look at individually, case by case basis, and try to tackle them. And these are the factors of non-adherence in both diabetics and hypertension. Let us look at the highlighted boxes, the red boxes, which says plus. That means there are the positive factors in the treatment approach. For example, in diabetics, the younger patients oblige more to the physical activity and the insulin administration. They are more stricter, like type 1 diabetics. And the males adhere more to physical activity than females. And this is where we need to look at the social support or the entire family support. And in diabetics, that is what we looked at. In hypertension, the complexity or the simple dosing regimens fare well compared to the complex regimens. And perception of the health risk related to the disease, active participation in monitoring or in the management of the disease, healthcare related will be something like simplification of regimens, education and use of medications, and finally, the good relationship between the bonding between the patient and the physician and simplified regimens definitely score over the other factors. Now, what are the methods of identifying? We were trying to ask the audience, and this is what it is. It has to be multi-pronged. There is no one system which fulfills all the criteria. It can be in the interview form, the questionnaire form, the digital form, or direct observation treatment, electronic monitoring. All these can be individual based, and that is how we detect the patient's non-compliance to the products, that is the IP. And strategies, what should be the strategies? As we discussed earlier, it has to be at the physician level, patient level. Lot of times we have inertia to up titrate a drug, to add on a second or a third drug, and that inertia, we should come back and come out of that. And we should be able to provide information about the disease, the risk factors involved, the complications involved. As a physician, we should take patient into confidence, and the patient empowerment has to be done. And we should assess them, and the resolution of individual barriers to adherence in a case-by-case basis we need to look at. At the patient level, we should encourage them for self-monitoring of the home monitoring of the blood glucose or the BP. Group counseling definitely works better when the similar pattern of patients are pulled in and give a group education. They would feel comfortable, and use of reminders, phone calls, all these definitely help the patient at the patient level. At the drug treatment level, again, it goes back to the simplest regimen will they do better. Healthcare system wise, the cost implications, the reimbursement of the bills, and the recognition by the ESIs, the CGHS, all these factors definitely matter. And 2017 ACC/AHA recommendation clearly said it's a class 1 recommendation that in adults with hypertension, the dosing of antihypertensive medications once daily rather than multiple times daily is beneficial to improve adherence. So it is very, very important that we should give the simplest form of regimen to most of our patients. So let us have one more question. How would you modify treatment regimen for our patient? Single pill, changing dosage regimen, that means you want to increase dose and reduce the frequency, omit any drug, or dose modification, and none of the above. So this is for our patient, CK 55 years, who is on single treatment of metformin, glycoside, ACE inhibitor, and a diuretic, and multivitamin and calcium. This is what the patient was on.
Right. We'll just wait for 10 more seconds.
Yeah. So single pill combination or monotherapy, changing the dose regime, you can also do. Omit any drug and dose modification. You want to add on a drug, bring in a drug, up titrate a drug, but it has to be simplified version because this patient is already fed up of his multiple doses and multiple drugs.
So 75% have voted for 1, that is single pill combination over monotherapy, and 25% have voted for 2.
Great. I think both are practical as long as you spend time with the patient and you educate the patient, both can be done. Absolutely, both are correct. So let us look at this evidence-based era, what we are going through. We need to have some clinical evidence for these combination pills. So you can see here a meta-analysis of 3 studies which has shown clearly that there is a higher adherence rate among the fixed dose combination compared to the usual care. So this is what is the result. 44% adherence was better in a combination pill compared to individually when you give these drugs. Again, another evidence meta-analysis, 9 studies, more than 11,000 patients involved, and look at all these. The standard deviation is to the left, which favors a fixed dose combination in both risk of non-compliance in hypertensive cohort in all these 9 studies, and it reduced the risk of medication non-compliance by 26%, and it should be considered in patient with hypertension for improving the treatment compliance. So the compliance increased by about 25%, and the non-compliance came down by 26%. So this is what is for a better clinical outcomes in the long run. Again, you see this Picasso study, which showed that initiation or switching treatment to ACE and diuretic combination reduced about 30 by 13 millimeters of hypertension, and 88% patients showed excellent tolerability and felt better at the end of 3 months. So 3 months follow-up in grade 2 and grade 3 antihypertensives, combination drug was put, BP was well controlled by 27 by 13 millimeters respectively, and about 90% of patients felt better. And that is what we should create when we treat our patients, the feel-good factor with whatever the regimen we prescribe. Now, the last question, how often do you consider guidelines before deciding a treatment? Always, most of the times, rarely, or never. Do you go by the evidences, what is told by the various guidelines, or you go by your experience? As I said earlier, we need to look at the guidelines, but guidelines doesn't mean it's a blanket treatment for everyone. It is to be individualized case by case basis.
So 100% has voted for always.
Great. So we need to keep backdrop of the evidence, and let us look at 2020 ISH guidelines, which clearly says single pill combination and about the multiple drugs are often required to reach target levels, especially in diabetic patients. Replace multiple antihypertensive agents with single pill combination. Single pill combination or monotherapy should be considered for initial antihypertensive therapy. So this is something we need to keep in mind. So do not hesitate. Please come out of the clinical inertia that the first time somebody is diagnosed has to be on single drug, though his BP is 160, 100. Please do not hesitate to have a combination pills. And clearly the guidelines recommend, they strongly recommend ACE is combination with the CCB or ARB with the CCB, or ACE or ARB with the diuretic. This is the commonest complication, especially in our diabetic patients, what we should think about. What does the ADA say? Single pill antihypertensive combinations to improve medication adherence in patients for treatment of confirmed hypertension with diabetes. So again, ADA 2020 clearly talks about 2 agents when the BP is more than 160, 100 in the diabetic background. And again, they talk about ACE, ARB, CCBs or diuretics based on the patient. So we need to talk about our patient now. How do you manage improving adherence in this patient? So what are the options? You start on an ACE inhibitor or diuretic combination once a day, metformin glycoside combination again, simvastatin OD, vitamin and calcium, diet plan, physical activity, patient counseling, and this is what we can definitely be, this vitamin and calcium supplements can be withdrawn at least for temporarily in this patient, I would say. And this is what you go ahead, combine these two, so the pill burden comes down, and definitely counsel about the diet and exercise, re-emphasize on that, and patient counseling has to be done on the complications and the importance of adherence and how you end up, and bringing down 1% A1C or bringing down 10 millimeters of BP would translate into a lot of advantages to the patient. So to summarize, poor adherence can lead to poor health consequences. Barriers to optimal adherence may be linked with physician attitude, patient beliefs, and complexity of the regimens what we prescribe. And the assessment of adherence should always be conducted if in a no blame approach, and should favor an open discussion to identify the specific barriers to each patient and try to tackle them. So individualized approach should be followed. Patients should be encouraged to take responsibility for the health, and suboptimal daily use of the prescribed regimens are the most common facets of poor adherence. We should remember that. And treatment regimen should be simplified by avoiding prescriptions of unnecessary drugs and using single pill combination or multiple monotherapies based on the individual clinical profile of patient to facilitate long-term adherence. So thank you very much for the patient hearing.
Thank you, Dr. Murthy, for a very lucid presentation, and also stressing the need for adherence to the medications, and also what one could do to achieve good adherence to medications. Well, I think the literature is very strong, and all of us are definitely, even Dr. Ambujal also vouch for that point, that we all of us are looking into reducing the pill burden, and then the single pill combination is definitely taking up everywhere. Whether it's the United Kingdom, whether it's the European society, or even in the so-called Western country, where again the problem remains. The adherence to Medicare is not just in India alone, but I think, but the major factor I would would like to re-emphasize is, when you talk about a single pill, it should be an affordable single pill combination. I think that's the key, because time and again we see this. No, when you have a combination, it's much costlier than an individual prescription. So that is something which is very important. I think it should be affordable. That issue also has to be borne in mind. In fact, none of us probably spend that kind of a time with a patient with hypertension and diabetes. It's very important that we really look into the reasons why they don't adhere to the therapy. I just would like to bring the latest recommendation for the International Society of Hypertension. For a poor country like India, I think it is they have stressed the need for a low dose combination pill. In fact, even if you don't go for a monotherapy initially itself, you can start a low dose, which probably works better. And also, one more thing I wanted to state is, I think today, at least in a state like Kerala, I don't know how the rest of the country is, the technology is taken up, at least in the setting of a mobile phone. In fact, I'm amazed to see the kind of the smartphones that our mason or carpenter, I am not trying to
degrade them.
Degrade anybody. That's not my question. But then I'm happy to see that entire people have a smartphone, at least the youngsters. So why not use this digital platform to at least improve the adherence? You can have a chat with your doctor, and then I'm sure Dr. Ambuj will give us a real insight into this. Have the blood pressure tacked up, have an app where this can be stored, which is done in most of the Western countries. And also very simple thing like, when you have your sugars checked, you have a reading there. When you check your blood pressure, the patient should go out with the reading in their hands. That itself is a key. Somebody, you write on a piece of paper 150, 110, that seeing that itself scares him. I think these are a few comments that I've got to make. And Dr. Ambuj, what do you feel about it?
I think you have to unmute, sir. Dr. Ambuj, you have to unmute.
So an excellent presentation and very pertinent questions, because seeing poor patients and being a poor doctor, I would especially mention the cost factor, because we are looking at chronic conditions here where you have to take the medicines for years, and the cost is an extremely important factor in management of these conditions. Because typically patients would take it for few years and then skip it. So that is extremely important. And as far as possible, good quality generic medicines is something I believe that should be part of the universal health coverage. Because we have 20 crore hypertensives. Look at the numbers, and unless we have the public health system coming in to help them, it'll be very difficult to get good control of blood pressure in the population. And as for the technology, again, I agree completely. In fact, sir, we have this platform which we had developed called the Empower platform, which has an electronic decision support system, and it generates. So we've used it in peripheral health settings where it generates a prescription which is vetted by the medical officer. It's used in the state of Tripura. We have implemented that. And this also, has these reminders for refills, which we send as SMSs, which we are saying on a monthly basis to improve compliance, which is again extremely important. And there is whatever way we can leverage technology in today's day and age will be very important, because ultimately compliance is the central to the management of these conditions.
Adding on to that, sir, about technology, we have got apps now, the EMRs. There is an app which patient can download, Android and iOS both, and they can feed in and we can reply based on the readings of glucometer readings or the BP readings. We can titrate it. So every day I get about 10-15 patients feedback like that, which I would have told them once in 15 days or once in 10 days, they have to upload their readings, and we can titrate the dosage just by an SMS. So it's so convenient for the patients as well.
Actually, to some of my patients, in a jocular way, and I tell them, see, you talk about investment. It's not like buying property, cars, but a few small things. Somebody gets admitted with an AMI, acute heart failure. I tell them, buy a glucometer, buy a BP apparatus, and a weighing machine. In fact, we have done quality control programs, and so we find that this, when your nurse follows up with these kind of readings, they do well. And in fact, it's for the entire family. This investment is for the entire family, not for just one person. And take leave out of this SPC, single pill combination. I think in the near future, you'll see the heart failure medication is also going the same way. You now have a long list of drugs that you need to take. So unless you have to combine this, you will not have the. So I think that's something in the offering. Dr. Nishita, can we have a question Q&A, and then I think we should be actually.
Yes, we are running. Yeah, we are overshooting the time. So we will just have one question. Dr. Mitra from Kolkata asks, in rural government hospitals, hypertensive and diabetic patients often have to consume multiple pills as combination pills are not available. In such cases, compliance is always poor as they may forget to take medicines timely or think that so many pills might harm them. How do you counsel such patients to improve compliance?
It has to be counseling again. There's no option because you're talking about a government setup backdrop. So there is available as only single pills. So you need to spend more time with the patient and talk to them, explain them which medication is for what and what does it control. As sir was saying, it's an investment for the family where you're going to prevent a future heart attack or a stroke in their own language. I think we need to spend time. And once you spend time, patients will definitely, like I conduct clinical trials, and it's not a joke to convince a patient or to talk about a consent a patient, not convincing, that term we're not supposed to use. It's a consenting, audiovisual consenting. Many out of 10, only one patient accepts for a audiovisual consenting. But still we try to make them understand the participation in a clinical trial because we spend time. I spend at least about 30 minutes to explain about a consent and then another 1 hour for a consenting. So similarly, for such patients where we identify that it is difficult for these patients to have a combination therapy or a branded treatment, we need to spend time and counsel. That's the only way out. Any point you want to add, sir?
I would just add that it's very important, opinion leaders like CSI and should now advocate for use of, combination pills through government agencies, because that's extremely important. Virtually every hypertensive, as you see the guidelines, needs at least 2 pills. So
combination
should start with a combination pill, and that is something which should be advocated. And if it's available on a mass scale, as Dr. Dekapal was saying, I'm sure the prices can be much more economical if you have bulk purchases, as governments do.
Yeah, this is very common with the CGHS patients. A lot of these CGHS, they have only one pill each. They never get a combination drug, and I would have prescribed 4 and they would come up with some 10 drugs individually showing this is what they've given us.
So, yeah, Dr. Nishita, I think we have had a really wonderful 1 hour, 2 brilliant speakers, and I think I'm sure the entire people who would have listened to this would have gained quite a lot. I gained quite a lot from these 2 lectures, and I really look forward to future meetings like this. So final word, Dr. Nishita, I think.
Yes, I will take over. So thank you so much, Jai Gopal sir, for moderating the session so well. Thank you, Murthy sir and Ambud sir. Extremely interesting and insightful session. I'm sure the audiences would have a lot of learnings today, a lot of key points to take with them. With this, I would like to end the session. I would like to thank the audiences also for your active participation. And again, in this fight of COVID, thank you so much for those people who are leading this fight in one way or the other and helping this country get out of this crisis as soon as possible. A big thank you for your selfless service. So thank you so much. We hope you had a good 4 days. So 2 last weekend and this weekend, 8 sessions, 8 interesting sessions, and you have a good, so we hope you had a good learning over a period of 2 weeks. And thank you so much for your participation. Thank you all the speakers and our speakers today also, and the moderator today.
Thank you, sir.
With this, I would like to end the session. Stay healthy, stay safe. Thank you.
Take care. Good night.
Good night. Good night.
Good night. Good night.
Thank you.
Thank you. Thank you. Are we off?